we'll start with cervical disc disease. Cervical spondylosis is a natural part of the aging phenomenon in the cervical and thoracic and lumbar spine. And the pathology that you see includes disc desiccation or drying out of the disc, narrowing of the disc space, bulging, and each cervical disc has a little bit of intersegmental lordosis, so as it collapses, it becomes slightly kyphotic. And that kyphosis is important in what we see later in terms of cord compression and thinking about treatment. You see uncinate spurring here, you see facet arthrosis, and you see disc herniations. The most involved level is C5, C6. After that, the most involved levels are C6, 7, and then C4, 5. And some of the risk factors that have been identified in the literature include a history of lifting, a history of cigarette smoking, and a history of driving. There are basically three flavors of problems that you can have with cervical disc disease, and they certainly overlap to a large extent. And many times you'll have a combination of the three. But you can have discogenic axial neck pain. You can have radiculopathy, which oftentimes is broken down in the old terminology that people used to use as a hard disc, which is a bone spur causing nerve root compression, or a soft disc, which is a true herniation of disc material causing nerve root compression. And again, many times you see sort of a... And you can have myelopathy. And many times you can have 2 or 3 of these 3 together. And this is true really probably throughout the musculoskeletal system, certainly true throughout the spine, that there is a very significant rate of false positive, or more precisely, clinically insignificant abnormalities seen on MRI scan. And if you survey 100 normal volunteers, no history of neck pain, under the age of 40, probably a good number to remember, is 14% will have either bone spurs, stenosis, bulging discs in the cervical spine. Over the age of 40, that goes to 28%. So it's really important for the boards and in your practice to recognize that when you're looking at an abnormality on an MRI scan, it may have nothing to do with the patient's complaints of pain. And plain x-rays are basically completely nonspecific. They show lots of pathology, but the pathology has very little predictive value as to what actually is the cause of your patient's problem. Also remember, and this kind of thing will frequently appear on the boards, in the cervical spine, it is always the lower numbered nerve root. So at C5, 6, it is always the C6 nerve root. At C6, 7, it is always the C7 nerve root that's involved. And remember to know the neurofindings. Almost without a doubt, there will be a question on the test where they'll show you something easy. Oh, this is clearly a C6, 7 HNP, and they'll expect you to recognize, well, that's triceps weakness, or that's a decreased triceps jerk. These should be gimmies. You should know this. It might take you 15 minutes to review your neuroanatomy and physical exam stuff in Hoppenfeld or whatever for the cervical and lumbar spine. And that's a question you know is going to be there. Now, how do we manage cervical spondylosis? Well, for acute neck pain, what I do is nonsteroidal anti-inflammatories. The use of a collar is very helpful, particularly at night. And moist heat is extremely helpful. We then progress, if the patients don't rapidly get better, into physical therapy. Traction is extremely helpful in the cervical spine, not in the lumbar spine. And there's a variety of different injections that are gaining in popularity as our neuroradiologists and various specialties become familiar. And there was just an article in the latest JBJS. That article is not likely to appear on the boards in 2 months, but just goes to show you how common these injections are and the familiarity you should have with facet blocks, nerve root injections, cervical epidural steroids, etc. What are the indications for surgery? Well, in general, the indications for cervical radiculopathy would be a persistent, painful radiculopathy that lasts at least 6 weeks. And we'll see this again in the lumbar spine. You don't jump right away just because somebody has a little sensory loss or a little bit of weakness that they need surgery the first week they've had symptoms. But if they have persistent, painful radiculopathy after 6 weeks, if they're not getting better, don't hesitate to operate. Certainly if they have progressive and significant weakness, and that's not common, that would be an indication to operate. In general, if they give you a case of myelopathy, they usually want you to operate. If it's clear-cut myelopathy, if it's in somebody who's not on death's door, usually they want you to say you would operate. And in general, the MRI scan should be reserved as a preoperative test. You don't get an MRI scan 2 days after somebody develops symptoms for a number of reasons, one of which is all those false positives, and the other of which is most of those patients are going to get better. And don't hesitate on the boards and in your practice to operate when it's indicated. You know, if they give you a clear-cut case of somebody with a decreased triceps jerk, pain down the hand, numbness and tingling in the hand, 12 weeks of symptoms. Don't feel like, oh, God, spine surgery, it never does well, and that's all true. But they don't want me to say operate, that's too aggressive. If they're giving you a case where it's calling for surgery, check the box that says surgery. What are the surgeries that we do? Well, certainly in orthopedic surgery, the most common operation and the one that they're typically going to be looking for on the boards in the cervical spine is an anterior cervical discectomy and fusion. That's the most common operation, and you really should think twice before you check anything else for single or even two-level cervical radiculopathy. Some other options include a keyhole foraminotomy, which is a nice approach in somebody with multi-level spondylosis, but who has a unilateral, either one or two-level radiculopathy. I doubt they're going to expect you to pick that. I would avoid anytime you find yourself saying laminectomy, you really ought to say, boy, laminectomy, that's in the cervical spine, that's not something that really most orthopedic surgeons think is a very good approach. There's still a fair amount of debate as to whether autograft or allograft is ideal. Many orthopedic surgeons use autograft, but many people now are moving towards allograft or various combinations, and plating is becoming increasingly widely accepted. Probably for a single-level fusion with autograft, you don't need a plate. But much beyond that, a two-level fusion, three-level fusion, I think the consensus seems to be that plating has real benefits, and a lot of people are using plating even for single-level fusions, and the benefits of plating maybe outweigh enable you to use allografts. So I wouldn't hesitate to say plating, certainly if you get beyond a one-level fusion. You need to know the Smith-Robinson approach. You need to know the way you cut through the platysma, the planes that you go through, and you need to know the complications of the Smith-Robinson approach. And it doesn't hurt to familiarize yourself just with some of the landmarks. What's at the carotid tubercle would be about C6, for instance. Know those things. That's the kind of thing they might ask you. What are some of the complications? Well, the number one thing that I think you're likely to be tested on is recurrent laryngeal nerve injury. It's more common on the right than on the left because the recurrent laryngeal nerve is more likely to have an aberrant course and come across the neck higher rather than going down into the chest and coming back up under the trachea. It's less common on the left. If you see it, the most common thing is to watch. Most of the patients will get better with time. If they're not better after about 6 weeks or so, then the standard thing is to get an ENT consult. Now, in actual fact, most of the time, if you know you have a recurrent laryngeal nerve injury, you'd probably get an ENT doctor to see the patient earlier. But the standard is 6 weeks, you get an ENT consult, they scope the patient, and if the vocal cords aren't moving, they can inject like a Teflon substance in that does improve the patient's function quite a bit. Some of the other complications include airway problems, more common in revision surgery, multi-level corpectomy, more common when the patients are myelopathic. It is one of the few potentially fatal complications we see in orthopedic surgery. Another potentially fatal complication is vertebral artery injury, most likely when you're using a high-speed drill, drilling out the bone. Neurologic injuries are actually quite rare in anterior cervical spine surgery. Pseudarthrosis is common. And even in more recent reports, you still see a fairly high rate in those who look critically of pseudarthrosis. Most of the time, they're not symptomatic, and certainly if they're asymptomatic or minimally symptomatic, or if the symptoms can be controlled with non-operative treatment, you leave them alone. The presence of a pseudarthrosis it does not require surgery unless you can't get the patient comfortable without surgery. But if you can't, there are advocates of either an anterior fusion or a posterior fusion, revision anterior fusion with plating, or a posterior fusion with either wiring or plating as a salvage operation. It's very interesting in an article in last year's JBJS, and the kind of thing they could conceivably ask you about. If you ask patients the rate, and this article was about dysphagia or dysphonia, again, recurrent laryngeal nerve problems, patients report an incidence of problems 7 times as high as what the surgeon has in his or her chart. Now, cervical myelopathy is another thing that you will see with cervical spondylosis, and some of the pathology that goes with it includes congenital stenosis, patients who are born with or develop a pre-existing somewhat narrow canal, spondylosis, where the patient has anterior bars, osteophytes at the disc space from degenerative change, and as I talked about, as the disc collapses, the neck collapses into slight kyphosis, and that causes the cord to be drop anteriorly against those anterior bars. And it's very common to see ossification of the posterior longitudinal ligament, particularly in Asian populations, but it's also seen in whites and in blacks, but the most common is in Asians. And you certainly can see combinations of these things. It's relatively uncommon, although not unheard of, to see someone with a normal-sized spinal canal have so much spondylosis they get stenosis, or someone with congenital stenosis start to get symptomatic until they start to develop degenerative change. What are some of the clinical sequelae of cervical myelopathy? Well, the hallmark sign and or symptom is gait deterioration, and it's certainly considered the most significant complication of cervical myelopathy. It's what some grading systems are based upon, and the classic myelopathic gait is a broad-based shuffling type gait. Another thing that you see, I think you see equally as commonly if you ask about it and look for it, is upper extremity weakness and clumsiness. If you ask the patient, do you have trouble buttoning buttons? Do you have trouble, a lot of women knit or darn or things like that, people will tell you, yeah, you know, I do feel like my hands are a little bit clumsy. There's something called a myelopathy hand where you lose intrinsic function and the ulnar fingers will drift out if you ask the patients to hold them out straight, or you can actually see intrinsic atrophy in more advanced cases. You will usually see upper motor neuron signs, hyperreflexia in the upper and certainly in the lower extremities, upgoing toes, clonus, a Hoffman sign. The problem is oftentimes you don't see that, or in the lower extremities, because you tend to lose your reflexes as you get older. You get a 75-year-old man with 2+ reflexes at the knees, that's abnormal. So you need to be aware of the fact that really normal reflexes in the elderly are very likely pathologic. And you can't exclude the possibility of myelopathy just because you don't have overt upper motor neuron findings on the patient. You have to look for other things, some of the other signs and symptoms, and the radiographic findings. It is fairly uncommon, although certainly not unheard of, to have involvement of bowel and bladder function. The natural history has been studied fairly extensively, and it is progressive. It's usually relatively slowly progressive. If you follow patients for a relatively short period of time, about 75% you won't see much change, and about 20% will show slow, steady decline. But if you follow patients for 10 or 20 years, most of these patients will slowly deteriorate. And that's why most of the time, if you see someone who's a reasonable surgical candidate who has myelopathy, there's really not much place for non-operative treatment. How do we make the diagnosis? Well, this is one case where the x-rays can be helpful at least. They are certainly not diagnostic of myelopathy, but they can be diagnostic of relative stenosis. The AP diameter of the canal on a normal, good lateral x-ray should be about 17 millimeters. And if you measure the AP diameter and it's less than 13 millimeters, and this is the kind of number they could question you about, that equals stenosis. Pavlov and Torg wrote up what's sometimes referred to as Pavlov's ratio, and they say that the ratio of the spinal canal to the vertebral body diameter should be 1:1, and if it's less than 0.8, that equals stenosis. That's not really as helpful as the absolute measurements. The other thing that you'll almost always see in somebody who does have cervical stenosis and myelopathy is you'll almost always see some degenerative change and some loss of lordosis, if not collapse into kyphosis. And it's important to recognize that in terms of your surgical decision making. Really, the test of choice is an MRI scan. And what you see is stenosis, narrowing of the spinal canal with actual compression on the cord, and you'll see flattening of the cord on the axial views, and this is actually just a pathology specimen. And you can see the way in this myelopathic patient, the AP diameter of the canal is decreased, and actually the side-to-side dimension is increased. That's referred to as the compressive ratio. If the ratio of this AP to lateral is less than 0.4, that's considered highly significant and has a poor prognostic ratio. Not really a measurement that's very easy to make clinically on either a post-myelo CT or an MRI scan, but it's the kind of thing that is in the literature. And the other thing that you'll see, and I think many times it's sort of considered a very significant finding in terms of saying, look, you need to have surgery, is myelomalacia, or signal change in the cord. It's most easily seen on the T2 weighted images. When you see that bright signal, you can tell the patient, look, you're injuring your spinal cord, and that's why it looks bright white like this, and this is not something that you should probably be sitting on. What's the treatment? Well, the role of non-operative treatment is really debatable. It would not be much different than the non-operative treatment of neck pain in general, but basically, if you have somebody who is clearly myelopathic, and if you're in doubt, I'll sometimes bring a patient back a month later and re-examine them and see, you know, if you're just saying, gosh, I thought I saw a Hoffman sign, I'm going to operate on this person, you know, maybe bring her back a month later and make sure, do they clearly have upper motor neuron findings? But if they do, and they have the stenosis and cord compression on the imaging studies, really, I think what they're looking for you to do is to operate. And there's almost no age at this point in time where you would say, well, you're too old. When I was a fellow, people used to say 70 years old. Well, as you all know, 70-year-olds are, you know, they're middle-aged nowadays. If you see gait changes, that's an indication for surgery. If you see any sort of progressive involvement, that's an indication for surgery. And really, any discernible diminution in hand function is an indication for surgery. Just upper motor neuron findings in somebody who's got a stiff neck and really isn't too keen on the idea of surgery, you know, maybe you watch that a little bit. But this is one condition where most of us are relatively aggressive in at least considering the idea of surgery. What is the surgery? Well, on an orthopedic exam, for the most part, they're looking for you to say anterior surgery. And if they give you a straightforward case, you know, big-time stenosis at 1 or 2 levels, they want you to go anteriorly and either do a corpectomy and a strut graft or an anterior cervical discectomy and fusion. You can do multi-level ACD and fusion or a corpectomy, or what some cervical spine surgeons like to do is they'll do a partial corpectomy and put a strut between the 2-level discectomy and then plate it, for instance, rather than just putting multiple horseshoe-type grafts in. But I think the key is they want you to be thinking about anteriorly. You can go as high as up to 3 levels just anteriorly, although the problem is if you get into a 3-level corpectomy, the failure rate is really extremely high, even with plating and strut grafting, etc. So most of the time, they're going to want you to put a plate. The question is, under what circumstance would you do posterior plating in addition? And that's usually if you go beyond a 2-level corpectomy. And some people would say even a 2-level. And I realize this is not as clear-cut as you'd like me to be giving you the answer, but that's because it's a little, you know, there's a lot of debate about this. If they get, what they're probably going to do is give you something relatively clear-cut if they ask you a question like that, which is like a 1-level corpectomy. That you would do anteriorly only. Strut, plate, boom, you're done. Or a 3 or 4-level corpectomy, and then most people who write about this nowadays are doing that combined front and back. Anterior decompression, strut graft, posterior plating, and posterior fusion as well, so that you have a higher chance. Because the failure rate with multi-level corpectomy and anterior strut, plating, whatever, is very high. Halo does not really help that much, is part of the problem. And as we'll look at in a little bit, it doesn't really immobilize the subaxial spine all that well. Another approach is a laminoplasty. The problem with posterior approaches is that, as we talked about, in the cervical spine, as you become spondylotic, you lose your lordosis. So once the neck is in a neutral position, and certainly when it's kyphotic, you can do laminectomies, laminoplasties, you can do whatever you want. The cord is not going to drift back away from those anterior osteophytes. So you really need to look, and this is the kind of thing they expect you to recognize. You need to see, is the neck going to come back to neutral or beyond? If it's not, then you can't do a posterior approach. Now, one alternative, if you have a very flexible neck that is in kyphosis most of the time, but the patient can come back into lordosis, is to do a laminectomy and then do a posterior plating. And that locks the neck in extension, allows the cord to drift back, but you don't have to go anteriorly in that, for a multi-level disease. But if you have a patient who's in fixed kyphosis, then a posterior approach alone, laminoplasty, laminectomy, is not really going to help you. And you should be aware, now, when is a laminoplasty a good approach? Laminoplasty is a good approach for someone who has well-preserved lordosis, multi-level disease, particularly if they show you OPL, which is where it was originally described. The putative advantages of laminoplasty are that it avoids, because you preserve the posterior bony arch and the muscular attachments, your neck is not as likely to drift into kyphosis, and it preserves motion. The problem with laminoplasty is that you do lose a lot of motion. Most of the time you lose at least 50% of your motion after laminoplasty, and most of these patients have a significant amount of neck pain after laminoplasty for whatever reason. So that's why laminectomy and plating, if you're going to do plating, is better than laminoplasty and plating. And laminoplasty, I think, has kind of fallen out of favor. What are the results of surgery for cervical myelopathy? When Bowman's large series a few years ago, he found that 80% of patients had significant relief of pain, neck pain and radicular pain. And 90% of patients had some neurologic improvement. That's not, the traditional teaching is that what surgery does for cervical myelopathy is prevent you from getting worse. And that's one reason we want to intervene early, is because once you get bad, once you need a cane to walk, what we tell patients is, there's no guarantee I can get rid of that cane for you. Once you're in a wheelchair, there's no guarantee I can get rid of that, I can get you out of that wheelchair. In actual fact, probably they do get better and you can make them somewhat better, but that's not a reason to wait. I think we still want to be fairly aggressive in operating on these patients. The prognosis for surgical outcome, not surprisingly, the worse your myelopathy, the worse you're going to do afterwards. This is orthopedics. It's not too complicated. And the severity of cord compression and older patients tend to do worse. And again, the complications are basically just the complications of cervical spine surgery in general. You see more airway problems. You see more neurologic problems with severe stenosis. With OPLL, you're more likely to get dural tears because a lot of time the dura is gone with severe OPLL. Let's talk about the rheumatoid cervical spine. The neck is involved in about 25 to 80% of patients with rheumatoid arthritis, and some of the things that are associated with neck involvement include multi-joint arthritis mutilans. It's more common in disease. It's more common the longer you have the disease, and it's more common in steroids. Basically, the more involved you are with rheumatoid arthritis, the more likely you are to have neck pain. And the steroids probably don't cause it. It's the duration and involvement of the disease that say you're at risk for neck involvement. The pathology that's seen, there are synovial joints, both anterior and true synovial joints, anterior and posterior to the dens, and they get involved with pannus, which then damages and attenuates the ligaments and leads to ligamentous laxity. And when you see neurologic involvement in rheumatoid arthritis, it is not, with rare exception, it is not vascular or anything else. It's mechanical compression and needs to be treated as a mechanical problem. You all know the patterns that are seen. C1, C2 instability is certainly the most common pattern that's seen. The other patterns that you see include basilar invagination, which is sometimes referred to as superior migration of the odontoid, subaxial instability, or mixed patterns, the most common of which is C1, C2 subluxation plus superior migration of the dens. Probably mixed patterns are the second most common variety that you see. You should be familiar with the Ranawat classification. Class 1 are patients with neck pain and a normal neurologic exam. Class 2 are patients who have dysesthesias, upper motor neuron findings, but have normal motor strength. And Class 3 are patients who objectively are weak. 3A are patients who are still ambulatory. 3B are patients who come in a wheelchair. And you're already all aware of the fact that it is very difficult to do a neurologic exam on patients with rheumatoid arthritis for a variety of levels. If you have a fused great toe, it's a little hard to see if you have a Babinski sign. These patients are generally weak. There's a lot of things they can have, peripheral neuridities and a variety of problems that make it difficult to do a good neurologic exam. The diagnostic tools in rheumatoid C-spine include the flexion extension x-ray, which is really the most important. If that's normal, you're probably okay. The MRI scan is the other thing that's extremely helpful because you can see a big pannus around the dens, conceivably without instability, but typically if they don't have instability on flexion extension x-ray, it's relatively uncommon to see a problem. You can get flexion extension MRI, which can be helpful in some cases and certainly makes a nice teaching slide. Tomography is really very minimally, not very widely available nowadays, although it is extremely helpful sometimes in visualizing superior migration of the dens and sometimes in seeing exactly where the dens is in C1, C2 cases. You get most of those views now with an MRI scan. SSEP is sometimes helpful. Some centers talk about using it. We don't use it very much at Georgetown, primarily just because it's, unless you use it a lot, many times it's hard to interpret. You should be aware of some of these lines. It's a little hard for me to remember most of them. The one that I remember is McRae's line, which is across the foramen magnum, and the dens, just a good rule of thumb is the dens should never be up inside the foramen magnum. So anytime you see that, that's a bad thing. I have a hard time remembering these other lines. The easiest is, we'll skip that. The easiest is probably Ranawatt's line, which I think I have a slide of in a minute, but it's the easiest to measure, but it's not actually as good as the others. The best is McRae's line. And just look to see, is the dens ever up inside the foramen magnum? If it is, that's abnormal, and that's a problem. A fair amount is known about the natural history of rheumatoid involvement in the cervical spine. We know that atlantoaxial subluxation increases the longer you follow these patients. Once you start to get instability, it's going to get worse over time. We know that a common pattern is that patients frequently will have reducible atlantoaxial subluxation. In other words, they go from 8 millimeters back to 2 millimeters, and then eventually it becomes fixed for whatever reason. And then the disease progresses up a level, and they get superior migration of the dens. So it's not necessarily a good thing when dynamic instability at C1, C2 converts to fixed subluxation, because they may be getting ready then to advance the disease. And we also know that in rheumatoid arthritis, when patients have cervical myelopathy, it will gradually worsen and many times contributes to death. And there are estimates that as many as 10% of patients with rheumatoid arthritis die from involvement in the cervical spine if you do autopsy on these patients. So it is a very significant consideration, and there's still a lot of rheumatologists who I think tend to sort of neglect the significance of it or not want to let patients get treated for it surgically because of old literature about the great risks involved and uncertainty about the natural history. The natural history is fairly clear. Now, what do you do if you have a patient who you're doing an operation that you really like necks, shoulders, knees, anything but, not necks, hips, shoulders, knees, anything but the back, feet? Well, you need to take surgery if the patient has instability at C1, C2, and that's any patient with greater than 4 millimeters of motion, whether they have rheumatoid arthritis or anything else. The upper limit is 3.5 millimeters. So if they're 4 millimeters or more, they're unstable, and they need precautions. And the precautions include you need to alert the anesthesia team, this patient has an unstable neck. You should send the patient down to the operating room with the collar on, because your verbal warnings might not have taken hold, but hopefully the anesthesiologist will say, gee, what's this collar doing on here? And ideally, you either want to do an awake intubation if the patient needs to be put to sleep, or do some sort of regional or spinal block if possible. What are the indications for surgery in rheumatoid arthritis of the cervical spine? This is a favorite test question. Bowden and Bowman wrote an article 10 or 15 years ago now probably, where they showed that if the space available for the cord, which is also referred to sometimes as the posterior atlantodens interval, if that is less than 14 millimeters, those patients are at risk for the development of myelopathy, and therefore, if you have C1, C2 instability, and if the posterior atlantodens interval, or the SAC, is less than 14 millimeters, you should operate on that patient. If there's one number to take out of this section of the talk this morning, it's that number, because certainly on the OITEs, and that's on there every year, and I suspect on the boards it's a common question. In general, if they give you a patient with one of these C1, C2 instability, superior migration of the dens, if they're a Ranawatt 3A, meaning they have objective weakness but they're still ambulatory, that's the patient to operate on, because they've got a lot to preserve, and those are patients who are at very high risk once they're Ranawatt 3As. The controversy is, do you operate just because someone's a Ranawatt 2, because they have upper motor neuron findings but they have no weakness? Or do you operate on the Ranawatt 3Bs? And I would say nowadays with modern surgical and anesthetic and ICU techniques, yes. You don't just say, well, this person's in a wheelchair, she's too far gone to consider surgery. A Ranawatt 3B, if they fulfill the criteria, they have instability, they should have surgery. Some other numbers that appear in the older literature that probably are not as important as this 14 millimeters. Some people used to say if there was 8 millimeters of motion at C1, C2, that's an indication for surgery. You know, if the SAC is still, if they have a nice big spinal canal, I would say, unless they have unless they're a Ranawatt 3A, you might wait on that one. They're probably not going to give you that. If they have progressive instability, if it's gone to 3 to 5 to 7, again, I think you would probably still wait until they fulfill this threshold or they become a Ranawatt 3A. And then the other thing that I think is a very significant in practice is the presence of pain. You really don't read about this much when you're reading about rheumatoid arthritis of the cervical spine, but these patients have lots of pain, and my experience has been that this is a very good operation for helping with their neck pain and occipital headaches, and it's worth considering. If you have basilar invagination, that's an indication for surgery. If you see the dens in the foramen magnum, that's an indication for surgery. This is the Ranawat line, a line across the ring of C1. You drop it perpendicular down to the pedicle of C2. If that's less than 14 millimeters, that's indicative of basilar invagination or superior migration of the dens. And certainly, if you see the dens with compression against the brainstem, that's an indication for surgery. In subaxial subluxation, a canal that's less than 14 millimeters on your flexion view is an indication for surgery. If you objectively fulfill the standard criteria for instability, that's an indication for surgery. And almost invariably, this is usually combined with some sort of upper C-spine pattern. And the key is, whether in practice or on your test, the key is you really need to look at the whole neck on these rheumatoid patients, because many times they do not have an isolated problem. They'll have C1, C2 plus C3, C4, or if you look carefully, a lot of times you have to do a little bit more than the nice simple C1, C2 fusion. What is the cervical treatment? Well, for C1, C2 instability, the treatment is posterior spinal fusion. And I think certainly nowadays the standard is to use the Mogrel transarticular screws, which eliminates the need for a halo, basically. Even in a rheumatoid patient, a Mogrel fusion, which includes posterior wiring and the transarticular screws, you do not need a halo, even in these osteoporotic patients. If you just do a posterior wiring, in a rheumatoid patient, if you don't do transarticular screws for some reason, you can't get them, or their anatomy is such that the vertebral artery is at risk, then you need to use a halo. Their bone is soft enough that wiring alone in a rheumatoid has a very high failure rate. And you virtually never should do an odontoidectomy, resection of the dens, as a first stage procedure. Even if the patient is neurologically impaired, has a huge wad of pannus pressing against the upper cervical spinal cord, the pannus will typically resolve, and this is in the neurosurgery literature as well as the orthopedic literature, the pannus will resolve under a solid fusion. And so you should reserve this as a second stage operation, and it's rarely needed. If you have basilar invagination, you should fuse to the occiput. And when in doubt, either on your test or in your practice, you should fuse to the occiput. It is more surgery, but the fusion rate is significantly higher, and certainly the risk of developing superior migration of the dens or of it worsening, if you don't do it, is a significant problem. So if they have basilar invagination, again, if the dens is above the foramen magnum or into the foramen magnum, then you should fuse to the occiput. And for subaxial instability, the standard operation is a posterior spinal fusion, not anterior most of the time, all things being equal. And the complication rate is really not near, in the old literature, which the rheumatologists are all brought up on, there was a 10% mortality rate, 10% infection, 10 to 20% neurologic worsening. I don't think there's anybody from any of your programs that would tell you that that's what we see in modern practice. The perioperative mortality, unless you really have a extremely impaired patient, the perioperative mortality is 1 to 2%. The infection rate is certainly less than 5%. The risk of neurologic worsening is really negligible in most of these patients, and the success rate is extremely high. It's an operation that has gotten better over time, and which has changed the indications, I believe. Okay, let's just go through a few questions. This is the interactive portion of the talk. You evaluate a patient 1 year following anterior interbody fusion with autogenous iliac bone graft. He's had complete resolution of his preoperative arm pain, minimal neck pain, occasional occipital headache. Current radiographs demonstrated non-union. You should recommend Oklahoma. D? Right. Cervical isometric strengthening. You don't need to reoperate on somebody who really is minimally symptomatic, and the enemy of good is better. Telling this patient, this is going to get worse, or I can make you perfect now, is a big mistake. So D, correct. Which of the following is the most important indicator of clinically significant cervical myelopathy? Anybody? C, gait changes. That's the thing. When they give you somebody with gait changes, that's sort of the trigger. You want to operate on this patient, and that's most of the questions. They're going to make it clear what they want you to do. The question is out of the whole universe of orthopedic knowledge, just trying to remember what it is you're supposed to do. But they're really not looking to trick you. 6 weeks following a Smith-Robinson ACD infusion, your patient's only complaint is of persistent hoarseness. You should order C, direct laryngoscopy. You can visualize the motion of the vocal cords, and if one is paralyzed, they inject this little whatever it is into it, and they really make significant improvement. 64-year-old man noted difficulty walking for a year and has a 3-month history of clumsiness in his right hand. He has a 5-year history of neck pain. On exam, he has brisk reflexes, including an inverted radial reflex. That is a reflex where you tap on the brachioradialis. It's a spinal cord release sign. Rather than doing this, the long finger flexors, because this cord is disinhibited by the stenosis, the long finger flexors contract. And that's called an inverted radial reflex, which is a sign of cervical myelopathy, specifically with cord compression at C6. Broad-based gait, and he has dysdiadochokinesia, which is difficulty with rapid alternating hand movements, as you know. X-ray and MRI demonstrate kyphosis from C3 to C7 with cord compression and flattening from C4 to C6. Increased signaling in the cord at C5. Treatment should include Rikio, where are you? Stand up. In the back of the room. You're halfway out the door. C? Right. Multi-level corpectomy and strut grafting. At least now I'm sitting on the floor and halfway out the door. Okay. A 37-year-old woman has severe bilateral arm pain, weakness in her wrist extensors bilaterally, an inverted radial reflex on the right, and a Hoffman sign bilaterally. MRI demonstrates a large midline disc herniation at C5, C6. All non-operative treatment has failed. What's the most appropriate surgical option? So she has a huge midline herniated disc and cervical myelopathy. And the right answer is D, anterior C5, C6 discectomy infusion. Now, obviously, there's some subtlety on the MRI. If the disc has extruded behind the body of C6, let's say, which is not uncommon, you may have to do a partial corpectomy to get at it. But you do not want to do a posterior approach, certainly. And you wouldn't need a corpectomy unless they specifically show you an MRI that shows that the disc is completely behind the body. Okay, let's talk about spinal cord injury. There are somewhere between 10 and 14,000 traumatic spinal cord injury cases a year. And it's far and away more common in males than in females. And the mode age, meaning the most common age at which it occurs, is 19. So the tragedy is this is really a disease of young people. It's more common on weekends. It's most common in the summer. And the etiology, although this is probably changing some. Historically, the etiology has been 50% of cases were from motor vehicle accidents, and then about 15% were from falls, 15% gunshot wounds, and 15% diving. There are some reports that gunshot wounds may be as high as 50% in some centers. And a lot of this depends on, if you're in a hospital that's right near a big highway, you're still going to see a lot of motor vehicle accidents. If you're in an inner city hospital, you're more likely to see penetrating trauma. It's important to understand the spinal cord injury syndromes because, again, this is sort of an old favorite, easy to ask, easy to be specific about, and you really should know these. A complete cord injury means that there is no distal function. So if they give you a case where there's any distal sparing whatsoever, sacral sparing, wiggling the big toe, a little sensation in the adductor compartment, that's not a complete cord injury. You've got to pick something else. To say that someone has a complete cord injury, either their bulbocavernosus reflex has to be intact, which means that they're not in spinal shock, or after 48 hours, for all intents and purposes, you can prognosticate. If someone hasn't recovered by 48 hours, even if their bulbocavernosus is out, it's safe to say if they're still complete at that point, they are, for all intents and purposes, complete. They will sometimes ask you about what things can be expected functionally for different levels of quads, a C5 quad versus a C6 quad versus a C7 quad. It's very hard to remember all that. In general, remember that C6 quads, meaning they have preserved anti-gravity strength in the C6 muscles. C6 quads can do a whole host of things that C5 quads can't. C7 quads can do some things that C6 quads can't, but C6 is the big jump. That's the golden inch, so to speak, of the cervical spinal cord, because if you can preserve C6 function, theoretically at least, that person can live independently, can learn how to drive, can learn how to do slide board transfers out of bed. There's really a lot of things that a well-rehabilitated C6 quad can do, so it's a vitally important segment if you can preserve it. And if you're going to guess on the test, and this is, obviously where some guessing may come in, just remember C6 quad is the one that usually is better function. Anterior cord syndrome, or sometimes referred to as anterior spinal artery syndrome, is the one thing that's most likely to mimic a complete cord syndrome with a little bit of function, because this is usually the most severe of the partial injuries. Usually involves loss of motor function, frequently complete loss of motor function, with some preserved sensation either in the posterior columns or maybe a little light touch sensation or whatever. But if you say, well, gee, it seems like a complete, but there's a little preservation, that's probably an anterior cord. And this has the worst prognosis, unless occasionally you see someone that makes a rapid recovery in the first few days. But other than that, if they're a severe anterior cord syndrome after a couple of days, those are the ones that are likely to do very poorly at final follow-up. They may have some protective sensation, but their ability to walk, for instance, is going to be minimal. Central cord syndrome is the most common of all the incomplete cord injuries. And one way I remember this is upper extremity involvement is usually worse than lower extremity involvement on first presentation. So there'll be 2/5 in the upper extremities and 4/5 in the lower extremities. But almost invariably, they will have preserved motor function. If there's no motor function distal to the injury, that's probably an anterior cord. But if they have some preserved motor, that's oftentimes a central cord, particularly when the arms are weaker than the legs. The late picture that you will see is a lower motor neuron picture in the upper extremities because of nerve root injury, so like clumsiness in the upper extremities, and an upper motor neuron spastic picture where they'll have like a spastic gait in the lower extremities. Central cord syndrome has a very good prognosis. Most of these patients are ambulatory at final follow-up. Most of them regain bladder control, but oftentimes they have clumsy hands. Brown-Séquard syndrome is usually seen with penetrating trauma, either gunshot wound or occasionally stab wounds or whatever. And it involves ipsilateral paralysis on the side of the injury with contralateral loss of pain and temperature sensation, classically 2 levels below the level of injury because those fibers ascend 2 levels and then cross the midline. This has the best prognosis of all the incomplete cord syndromes, with typically almost all of the patients ambulatory at final follow-up. What are some of the complications of spinal cord injury? Well, they include neurogenic shock. This is another of the rare orthopedic complications, and it was on my boards, that is potentially fatal. What you see is patients with hypotension and relative bradycardia. If you don't treat this appropriately, this can lead to death. When you see a young adult who is hypotensive, they should have a very brisk response in their heart rate. And if they don't, then that speaks more to neurogenic shock than to either hypovolemic shock or cardiogenic shock or whatever. The appropriate treatment is Swan-Ganz monitoring to be able to measure peripheral vascular resistance, which is lost in neurogenic shock, and to be relatively careful with the fluids. Now, when in doubt, you volume resuscitate a patient. But if you have a Swan in and you can tell, then, and you know it's neurogenic shock, then you want to use pressors rather than just volume. Skin is still a relatively common complication. The appropriate treatment is prevention, and the appropriate prevention is to address the skin in the emergency room. Make arrangements for either log rolling, special bed, etc. And do not leave the patient on the backboard. The backboard is a transport device to get the patient safely into the hospital, and then you institute measures to preserve the skin. Urosepsis used to be the most common cause of death in spinal cord injury. It's still one of the more common causes. And again, the treatment is prevention. Strict aseptic technique when you catheterize the patient in the emergency room. You leave the catheter in for about 3 days because many times these patients are diuresing. You don't want to let the bladder get distended. And then you take the Foley out at about 3 days and start frequent intermittent catheterization, usually every 4 hours to start with, because what you don't want is to get a volume of more than 500 cc's, and certainly more than 1,000 cc's is a real problem because it can take months or longer for the patient's bladder to contract. And what you're looking for is for the patient to be able to have a spastic bladder that will empty on Crede maneuver. And if they have a distended bladder, they're going to lose that potential. Autonomic dysreflexia is another potentially fatal complication. And the classic thing is you get called by the nurse several days or even weeks after a spinal cord injury. The patient has a severe headache, they're agitated, they're hypertensive, and this is usually because of unchecked visceral stimulation. And the two things you need to do are check the Foley, if they have a Foley in, to make sure that it's draining, put a Foley in if they don't have a Foley in, and disimpact the patient. If the patient is constipated, stretch the rectum, and they can go into autonomic dysreflexia. How do we treat spinal cord injury? Well, certainly, still in 2005, high-dose methylprednisolone, the high-dose methylprednisolone protocol from the NASCUS 2 and NASCUS 3 studies is still really considered, for all the controversy involved, and I recognize that there are a number of places where people don't embrace this. If you're not using it, you should have a good reason why. And certainly for test-taking purposes, I think they're going to expect you to know that this is the standard treatment, and they're going to expect you to know the dose, to have the dose memorized. You initiate it if you see or have access to the patient within 8 hours. After 8 hours, you don't use steroids. The contraindications would be penetrating injury, although some centers still use it for that, pregnant patients, patients under the age of 13. You should be aware of the dose. It's 30 milligrams per kilogram dripped in over the first hour. Or a good way to remember it in your typical 70-kilogram man is 2 grams. Then 5.4 milligrams per kilogram drip for the next 23 hours if you start it in the first 3 hours after spinal cord injury. If you don't get to the patient in the first 3 hours, so you're only getting to the patient between hour 3 and hour 8, the NASCUS 3 protocol says that you should continue the drip now for 48 hours, not just 23 hours, or I guess 47 hours. How else do we treat patients with spinal cord injury? Well, with steroids. The next thing is apply skeletal traction and reduce any sort of malalignment of the cervical spinal cord, fracture dislocation, a fracture with collapse. If the cervical spine is malaligned, it needs to be realigned. Now, who can you do that in? Well, you do it in the awake, alert patient. If the patient is intoxicated, unable to provide feedback, then you need to be very careful about realigning the spine. This specifically applies to facet subluxation or dislocation. When do we consider getting an MRI scan? And this is an extremely well, it's controversial and it's somewhat complicated, so I'm going to go through sort of what I think. I'm happy to answer questions at the coffee break because there's always a number of questions about this. The classic question they're likely to show you is somebody who has a facet, either subluxation or dislocation or unilateral, bilateral facet jump, let's say they're 25% off. The standard answer is apply skeletal traction and reduce it. When would you consider getting an MRI scan? Well, if you were going to take the patient to the operating room, put the patient to sleep, and either reduce them closed or open, you should get an MRI scan before you reduce that patient, if they have any preserved neurologic function. So let's go through the three extremes. One is if the patient is neurologically totally normal and has a dislocated neck. For that patient, I would always get an MRI scan first because the patient's normal. You can't make them any better. So why not get an MRI scan first, make sure there's not a disc herniation. Conversely, if the patient has a complete spinal cord injury, okay, in that patient, you can't make that patient any worse. So in that patient, I would always apply skeletal retraction and reduce the deformity, even going to the operating room and reducing it closed or open. Now, the exception might be if you're in a center where boom, 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 you can get an MRI scan in 45 minutes on your way to the OR. But in most places, that's not the case. But if there's going to be any significant delay in getting an MRI scan, if you have a patient with a complete cord injury, you can't make that patient worse. So better to get him to the operating room and hope for a miracle by getting his neck reduced. And certainly in the emergency room, if he's awake and alert, you would reduce that patient. The controversy is the patient with an incomplete spinal cord injury. And that's what they're likely to ask you about, I think. If you have a patient with an incomplete spinal cord injury, if they are awake and alert and they can give you feedback and they can say, excuse me, but I just became quadriplegic, could you undo what you just did? Then that's a patient who you would apply skeletal traction and reduce it without an MRI scan. If the patient is intoxicated, if the patient can't cooperate, and they're an incomplete spinal cord injury, you must get an MRI scan first. Or I would say you should get an MRI scan first before you reduce them. And I recognize that there are places like Jefferson where they reduce everybody. Okay. If the patient has an incomplete spinal cord injury and they've been cooperative, but you can't get it reduced, and you say, we got to go to the operating room and put this patient to sleep, then you should get an MRI scan before you reduce it. Okay? And again, I'm happy to answer questions about this at the break. I recognize that it's a relatively complicated issue and that there are some centers that do it differently and there's some conflicting data. One other thing that you'll see sometimes is gunshot wounds. When do you operate on gunshot wounds? Well, gunshot wounds in generally are treated non-operatively. And the exception would be if you have a fragment at the level of the caudate equina with neurologic impairment. Some people recommend, because that's a peripheral nerve, that's peripheral neurologic tissue, that you remove the fragment. I'm not sure that there's any good information to support that. And the other thing is, if you have a bullet wound that has traversed the colon, which makes it highly contaminated in the spine, there are some people who recommend debriding the bullet wound, although I'm not really sure that I've ever seen anybody do that. But certainly any other viscera, the stomach, the small intestine, you just put the patient on antibiotics. You do not need to debride the gunshot wound. Okay, just to go over the MRI question again, and then again I'll be happy to answer questions. You basically always do it before open reduction, with the only exception possibly being the patient who has a complete spinal cord injury. You certainly always do it if you're doing a reduction and the patient gets worse neurologically. Then you back off on the weight and you hurry down for an MRI scan. One thing that's in the literature is when you see acute disc space narrowing like this, where you have this young adult, nice juicy disc above and below, and C5 is sitting on C6. Well, where did the disc go? It's got to be back here somewhere. And that patient, some people suggest, is more likely to have a disc herniation in the canal behind the body of 5, where it's at risk if you pull 5 back onto 6. I would certainly consider it. In fact, I would want it done on my neck if the patient is neurologically intact. You do not get an MRI in patients of complete spinal cord injury. And again, we talked about what you do for incompletes. Patients with incomplete spinal cord injury are usually going to get surgery one way or the other. They're usually going to be decompressed when they neurologically plateau, which in many centers nowadays is, if they aren't getting better before your eyes, they'll go to surgery either the night of injury or the following day. Certainly, and if there's one thing to remember in spine surgery in general and with spine trauma, it is anytime you have a patient who is worsening neurologically, that's an indication for surgery. If there's one rule to remember, if there's any surgery to be done, if you have a patient worsening neurologically, that's an indication for not just surgery, but for emergency surgery. And in incomplete spinal cord injury, decompression may facilitate cord injury, but it almost certainly facilitates root return, and you may see as many as 1 or 2 levels of root return, which, as I talked about before in terms of function down the road, those 1 or 2 levels are very important. With complete spinal cord injury, in fact, we operate on most of these nowadays too, largely because we want to stabilize any instability so the patient can get into rehab and get on with their lives as quickly as possible. You want to minimize the need for a halo or any sort of orthosis if you can. And there is some evidence that if you decompress a complete spinal cord injury, that you will facilitate root return, 1, maybe 2 levels of root return. The problem is the complication rate is much higher, so that Bowman and Anderson in their series, and again this goes back 10 years now, so I think people are probably more aggressive, but Bowman and Anderson in their series said that under the age of 50, the risk-benefit ratio is favorable. Over the age of 50, the complication rate gets so high, and what you see is not really 50-year-olds most of the time. You see that second peak of spinal cord injuries, which is in the elderly patients, and those patients aren't going to do very well after surgery. Of course, they're not going to do very well after quadriplegia either, but so they have a very high complication rate. Let's talk about spine trauma in general. In Bowman's series from Baltimore City Hospital in 1979, he showed that 1 out of 3, 100 out of 300 cases, were missed on initial presentation, and that 5% of those patients deteriorated neurologically. And the sad fact is, although they were probably better than we were in 1979, we certainly still miss a lot of cervical spine injuries. And why do we miss these cases? Well, the reasons we miss them have not changed. We may not miss as many, but the reasons we miss them haven't changed. And that includes multi-system trauma, where people are concerned about chest trauma, head trauma, abdominal injuries, other life-threatening, very important injuries, but you're the one many times who has to keep your eye on the ball and say, you know, we haven't cleared the neck. We don't have these decent spine bones. We need to get a CAT scan of the C-spine. Head injury of loss of consciousness makes it difficult to do the things that we do. Does your neck hurt? Can we do a good neurologic exam? And also drug and alcohol intoxication, where we can't get a good neurologic exam or get a good response from the patient when we see if they're painful or tender in the neck. And those are 3 things that are still the most common causes of missed injuries today. It's mandatory to get an adequate x-ray of the cervical spine, and you must see the top of T1 in order to say, this is a good x-ray and I can clear the C-spine, if you will. If you don't have a good x-ray down to T1, then the standard protocol in most centers now is to get fine-cut CT scan down through the body of T1, and that is considered good enough, although it's not perfect, that in the absence of any other reason to continue C-spine precautions to clear the cervical spine. And there is a price to pay to just say, well, I can't clear this patient, forget it, I'll come back next week and try again. You know, the complication rate in the ICU is significantly higher in patients who have that collar on who are not cleared. They don't get aggressive chest PT, they don't get turned as often by the nurses, they don't get the same kind of nursing care. So you do want to try to clear the C-spine expeditiously if at all possible. Atlas fractures, or fractures of the ring of C1, are probably the most commonly missed injuries. And when in doubt, a CT scan is really the test of choice. Only 50% of C1 ring fractures are going to be isolated. Any time that you see a C1 ring fracture, you need to be aware that you need to look at the lower cervical spine and down into the thoracic spine, because they're associated either contiguous or non-contiguous, most commonly contiguous, but also non-contiguous injuries. On the open mouth odontoid view, if you see 7 millimeters of spread or more of the lateral masses, that means there's an associated transverse ligament injury and you have an unstable fracture of the ring of C1. What does that mean? Well, that means you should put the patient in traction, reduce that, and then they go into a halo. If you have an isolated transverse ligament injury with an intact ring of C1, if the CT scan is extremely helpful in being able to tell you, is it a pure ligamentous injury, in which case it's not likely to heal, and if they have instability on their flexion extension views, they probably need surgery. But if you see a bony avulsion, which the CT scan will pick up, most of those will heal in a halo. C1 ring fractures are often undertreated, and the standard, when in doubt, you should put the patient in a halo. And if they show you a C1 ring fracture and you're kind of not clear on what it is you're dealing with, I would go for a halo. That's probably the safest bet. Odontoid fractures are relatively common and easy to ask questions about. You're all familiar with the classification, type 1, type 2, and type 3. The type 2 fracture is the one where there's the most controversy. If you take all comers, 30% of type 2 fractures will go on a non-union in a halo. But fortunately, there's things that we can do to isolate what are the fractures at risk for non-union. And the most predictive factor for a non-union, and the thing that I think you're most likely to be asked about, is the initial displacement. If the fracture is displaced 5 millimeters or more on the initial x-ray, the risk of non-union in a halo is 50% or greater, and most surgeons will recommend surgery, and most patients are not going to want to spend 12 weeks in a halo, only to have a greater than 50% chance that they're then going to need surgery. So that would be considered an indication in most people's hands for surgery. Other risk factors include an irreducible fracture. If you can't get a near anatomic reduction, then because of the overlap of the dens, you don't have enough bony contact. That's a high risk for non-union. And that's another patient to consider primary surgery on. And the other person is, if you put somebody in a halo and you can't hold them reduced. You get them reduced, and then they redisplace. That's considered an indication for surgery, and that was a question actually on my recertification exam. The surgery can either be a posterior fusion or anterior screw fixation. There's a fairly significant complication rate with anterior screw fixation. A single screw is considered adequate fixation. Although 2 screws are better, it's very hard to fit 2 screws up the dens, so a single screw is considered better. Be aware of the fact that when you look at a dens fracture on the lateral x-ray, if you have an oblique fracture in this plane, then your screw is almost parallel to the fracture line and really does not provide good fixation, and that's a relative contraindication to anterior screw fixation. On the other hand, if you have an obliquity in this plane, then your screws are directly perpendicular, and that's the ideal fracture for anterior screw fixation. So also, if they clearly show you one of these sloping fractures, which you can see, that is not a good case for anterior screw osteosynthesis. That's a case to do posterior C1, C2 fusion. The problem with fusing C1, C2, as you know, is that you lose 50% of your neck rotation, so that there is a significant long-term downside to doing a C1, C2 fusion, which is why the non-operative treatment is good also. You see, there's a very high rate of odontoid fractures in the geriatric population. They're frequently missed, and very often you'll see patients come in where it's a week later, 2 weeks later. It's very hard to tell, is this a non-union? I would be very careful about putting elderly patients in a halo, because there's a very high risk of complications, including respiratory complications, pin problems, in the elderly population in halo. So these are patients in general that you either want to treat in a collar and hope for the best, or consider anterior screw osteosynthesis, or consider a C1, C2 fixation. And when you're 80 years old, although it's, you don't want to lose your motion, it's not quite the same consideration as somebody who's 25 years old in terms of loss of motion. But I would be very reluctant to put an elderly patient in a halo for an odontoid fracture, particularly since many times it's a non-union. And that's considered a contraindication to anterior screw osteosynthesis as well. If it's a non-union, most people will tell you you can't take down the non-union and fix it. Type 3 fractures, the consensus nowadays is a type 3 fracture which has a high rate of union needs to go in a halo to have a predictable union rate. Another fracture that you'll see is a hangman's fracture, which I guess is politically incorrect nowadays. Traumatic spondylolisthesis of C2, I guess, is the preferred term. It is a bilateral fracture of the pars of C2. The mechanism is a hyperextension injury, which fractures the pars, and then followed by an extension force, which is a fairly common coupled force that you see in motor vehicle accidents. And the flexion injury tears the posterior longitudinal ligament, tears through the disc space, and allows for the subluxation of C2 on C3. Most of these patients come in neurologically intact, obviously because if they came in neurologically impaired, they'd already be dead. And most of these will heal despite displacement, and is the rare hangman's fracture that you should operate on. There's really no good number in the literature that says how much displacement is considered acceptable versus unacceptable, but I would tell you, I would be very careful in practice or in the boards about saying, well, gee, this is so displaced, I don't think you can accept this, because if the patient's neurologically intact, which they almost always are, and if they will usually heal despite displacement. And what happens is, the way they heal is the anterior longitudinal ligament will ossify from C2 to C3, and they'll autofuse at that level. The treatment, therefore, is to reduce the patient in traction and then put the patient into a halo. The widely displaced ones, some people say you should hold in traction for as long as 6 weeks. I know very few places where they do that. The standard answer is get this as reduced as you can in traction and then put the patient in a halo for 12 weeks. Be aware there's a couple of subtleties. One is the type 2A hangman's fracture, where there's not much anterior translation, but there's a lot of angulation. You don't really want to apply traction to that patient because you can actually distract at the disc space, which you can see going on here. What you want to do is just manipulate, hyperextend the patient in bed, get this angulation improved, and then put the patient in a halo. And the one exception to the non-operative treatment rule is the type 3, which is a minimally displaced hangman's fracture with an associated C2, C3 facet dislocation. If you have that, then that would be an indication to operate to reduce the C2, C3 facet dislocation and do a C2, C3 fusion followed by a halo that will take care of the C1, C2 problem. If you could fuse C1 to C3, but the problem you then have all the morbidity of a C1, C2 fusion. But the type 3, which is rare, is the one indication for surgery in a hangman's fracture. Just to go back now to facet dislocations, which we talked about a little bit before. In general, if you have a unilateral jump, you're going to have a 25% subluxation of C5, in this case on C6. If you have 50% subluxation, that's likely to be a bilateral facet jump. Be aware of the fact that the risk and severity of spinal cord injury worsens with increasing displacement. That's not hard to understand why. The treatment is skeletal traction and closed reduction of the injury, usually followed by posterior fusion with reduction. Almost always nowadays, most of us will operate to fix these. Unilateral dislocations are harder to get reduced because many times with a unilateral dislocation, the posterior longitudinal ligament is intact, but they have a greater inherent stability, and sometimes you can treat those if you want in an orthosis. The bilateral dislocation, where most of the time the PLL is going to be torn, is much easier to get reduced, but much more unstable and more likely to redislocate in any sort of orthosis. So a bilateral dislocation is definitely an indication for surgery. And if you cannot get if you can't get the dislocation reduced, closed, then the treatment is an open dislocation, an open reduction rather, where you burr down the superior facet of the level below and then manipulate and do a closed reduction, do an open reduction rather, of, in this case, C5 on C6 to anatomically realign it, and then you fuse C5 to C6. And again, I talked before about the indications for MRI scan, and I will be happy to answer any questions that you might have at the break. Vertebral body fractures are also very common, and this is another high-risk injury for, or high-risk fracture pattern for spinal cord injury. There's a so-called teardrop fracture where the posterior inferior corner of the fractured body is broken off as a free fragment and retropulsed posteriorly. It usually goes along with a posterior ligamentous injury and is very likely to be associated with spinal cord injury. These are fractures that almost always need surgery. If you have a stable vertebral body fracture, a compression fracture, without posterior ligamentous injury, without disruption of the posterior cortex, then these fractures, without significant kyphosis, these will heal in a brace or a halo, but most vertebral body fractures in the cervical spine, except in the elderly, are going to need surgery. If there's a spinal cord injury, even complete injury, most of the time we will operate, as I mentioned before, operate early to stabilize the patient, because the most important part of that person's life is addressing their life-threatening injuries and then getting that person into rehabilitation as early as possible, which is shown to have a better long-term prognosis for return to meaningful function. And just beware of the posterior ligamentous injury, because it's easy to focus on the vertebral body, but that's a highly unstable fracture pattern. And if you see an associated posterior ligamentous injury, which is relatively common, with a vertebral body fracture, then you need to do more, either an anterior fusion with a strut and a plate, which is the preferred approach for most people, or an anterior fusion with an anterior strut and posterior plating. Just a word about ankylosing spondylitis. These patients, as you know, are at high risk for cervical spine injury. And be aware of the fact that if an ankylosing spondylitis patient comes into the emergency room with minor trauma, complaining of neck pain, they are at risk for delayed neurologic deficit, because they oftentimes will develop an epidural hematoma. The fracture pattern can be difficult to see, and they need to be followed extremely closely. And they need to be made aware of the fact that you're neurologically normal now, but any signs or symptoms of spinal cord involvement, they need to come right back to the emergency room, because it is not uncommon to see somebody in the emergency room, 3 days later they come in quadriplegic. and the pattern that is commonly seen as an epidural hematoma, which would be the one indication on your boards where they might ask you to say cervical laminectomy is the appropriate answer, although they would also probably expect you to say cervical laminectomy and fixing the fracture. And in general, because these patients are ankylosed for several levels above and below the fracture, whatever fracture pattern you see requires more aggressive stabilization than you might otherwise see. So if it's a minor fracture that you say, gee, I'd usually put that in a collar, that patient, you ought to probably put him in a halo. If it's somebody who needs anterior surgery alone, you probably ought to think about doing anterior and posterior surgery, because these fractures are difficult to stabilize because of those multiple ankylosed segments above or below. And just to digress a little bit about ankylosing spondylitis, as board-certified orthopedic surgeons, which the overwhelming majority of you, now having taken the Miller course, are going to be shortly, you should be able to recognize the difference between ankylosing spondylitis and DISH. Ankylosing spondylitis is the classic bamboo cane spine. These are marginal syndesmophytes. This is ossification in the anterior aspect of the annulus itself, not in the ligaments. This, on the other hand, is DISH, or Forestier's disease. These are non-marginal syndesmophytes which occur in the anterior longitudinal ligament, and this is not AS. And you should be able to recognize on X-ray the difference between those two patterns. One other C-spine injury pattern that I want to talk about is pseudosubluxation of the cervical spine. In the child, the facet joints are much more horizontal than they are in the adult, and that pattern changes by age 4 and becomes totally normal by age 8. It's most marked at C2, C3, while you can also see it at C3, C4. So what can happen is it's relatively easy for a toddler to pseudosubluxate the C2, C3 level with minimal trauma. How do you differentiate pseudosubluxation from a true subluxation or cervical spine injury? Well, there's a couple of things. One is there's a minimal history of trauma. Patient comes in, the mother says, gee, he tripped and stumbled, and now his neck hurts, so I brought him in, and he has this injury pattern. The other thing that's very helpful is the absence of compensatory lordosis. So in a true cervical spine injury, where you've subluxated C2 on C3, your body is going to become lordotic below to compensate for that. What you see in pseudosubluxation is the entire spine is flexed forward, and C2 is subluxated on C3 here. And the other thing is when you ask the kid or help the kid hyperextend the neck, under supervision obviously, you get this easy reduction of C2 on C3 with no need for manipulation. And that is the diagnosis of pseudosubluxation as opposed to a true traumatic C2, C3 injury. Anytime you see a C2, C3 subluxation in a kid under the age of 4, you should be highly suspicious that it's pseudosubluxation, because most of the time that's what it's going to be. Let's talk a little bit about, actually let's stand and stretch for 2 minutes. Don't leave the room unless you want to miss, because I'm going to start very soon. It's a Georgetown resident who was willing several years ago to pose for this picture. They don't make them like that anymore. Let me just freshen up my water there. Thanks.
Just the stretch. So with the ankylosing spondylitis and the cervical trauma, you say the next step, CT scan or an MRI? Because I've seen both. The OKU will say get the MRI to rule out the epidural hematoma. The OIT says get the CT scan because of the missed fracture on the brain
I think
film.
most fractures are going to show up on good MRI nowadays. I would probably get an MRI. If I had a person I was suspicious in the emergency room, I'd probably get an MRI scan.
And that's for both. Because you'd get an epidural.
I think you'd see both likely, yeah. Okay. All right, let's get started. Can you hear me? Okay. Let's talk about halo use. The halo is the ideal orthosis for use in the upper cervical spine. And in general, in your practice and on the boards, when in doubt, put somebody in a halo. It's a good idea to be familiar with how it's used. I think it's probably underused. It's, in general, highly effective. Be aware of the fact, though, that what the halo does is it fixes the skull relative to the torso. And therefore, it allows intercalated or paradoxical motion or snaking in the subaxial spine because of the mobility. And it's unreliable for immobilizing lower cervical spine problems, such as a facet jump. There's any number of reports of redislocation of a facet jump after reduction. It's really not an acceptable treatment to say, well, I reduced the facet jump and put it in a halo. It's not that great for stabilizing a strut graft after surgery, although it's certainly better than anything else we have, but you should be aware that it's not rigid fixation in the subaxial spine. It's widely accepted now that there's a significant rate of pin complications as the most common problem with halo use. And the pin that gets you in trouble is the anterior pin. And the way it gets you in trouble is if you put the anterior pin in the temporalis fossa. Why would you do that? Well, because it's behind the hairline for most people, and therefore you get, cosmetically, it's much more appealing. The problem is that the temporalis muscle moves when you chew, the bone is thin in the temporalis fossa, and you have a significantly increased rate of loosening and infection if you put the pin in the temporalis fossa. The recommended site is therefore anterior to the temporalis fossa and posterior to the supraorbital nerve. And although cosmetically it's not very appealing, you have a much, much lower loosening rate. And you should be aware of those landmarks. This is where the anterior pin goes. In adults, you use a total of 4 pins that you tighten to 8 pounds of torque. You go back the next day and tighten them again, and then you leave them alone. The complications include pin loosening, which you see in 36% of cases. And if the pin is loose, you tighten it. If it loosens again, you tighten it again. But if you can't keep it tight, then you'll replace the pin. If you have loosening plus infection, which you see in 20% of pins, then you replace the pin. If you only have infection, then you treat it with oral antibiotics. If the pin is not loose, but it's infected, you can treat it with oral antibiotics. But a loose infected pin has a significant risk of either puncturing the skull, which leads to bad things, or developing osteomyelitis of the skull, which again is a relatively bad thing, I would assume. Discomfort is present in 18% of patients and usually can be relieved by either loosening up the, making a little stab wound to relieve the skin a little bit. And dural puncture, which is a very bad thing, is seen in 1% of cases. In the pediatric patient, you use anywhere from 6 to 8% of pins because the bone is soft. You need more pins because you can't tighten it as much. And you use low torque, either 4 to 5 pounds, or some authors even talk about just finger tightening the pins in the pediatric population. And under the age of 2, because the skull is such soft bone, you can't use halo at all, and you use a Minerva cast. Let's talk about thoracolumbar trauma. In cases of thoracolumbar trauma, you want to first rule out multisystem trauma, which is commonly seen. You see head injury, you see chest injury, and it's very easy to miss a thoracic aortic injury, and you see abdominal injuries. And be aware with a chance-type pattern, the risk of associated visceral injury, which may be missed, is very common. They may show you a chance fracture and expect you to recognize that abdominal visceral injuries are common, or they may describe a patient with abdominal visceral injuries who has what appears to be a normal x-ray and expect you to recognize that patient. You need to be very careful about ruling out a chance fracture. In general, fractures between T2 and T12 are usually stable, but these are fractures with any sort of dislocation or subluxation that are at high risk for neurologic injury. In general, fractures at the thoracolumbar junction are much less stable because it's that transition phase between the rib cage and the mobile lumbar spine. You can see isolated conus injuries, which can be difficult to pick up unless you do a rectal exam and look very carefully for bowel or bladder problems. And it's also common to see a mixed neurologic pattern. So just because someone has intact L5 and S1 motors and can wiggle their toes up and down or their ankles with 5/5 strength doesn't mean that they may not have L2 and L3 injury, or conversely, they can have nothing distally and have preserved proximal strength. So it's important that you go through the entire systematic neurologic exam, rectal exam, hip flexors, quadriceps, distal motors, sensation in all dermatomes, to really identify. Don't just cursorily pull up the sheet, move your ankles, can't move them or can move them, and that's a common cause of problems, and it can really come back to haunt you because the next day when the neurologic picture is more thoroughly done and it's different, and you're saying, well, now is this different? Is this worse than it was yesterday or better depending? So you need to do a thorough neurologic exam in all patients, but in particular with the thoracolumbar junction trauma. And in general, fractures from L2 down involve the cauda equina, which neurologically have a significantly better prognosis. And you really can't, by definition, see a patient with a complete injury at that level because the cauda equina does at least have the potential for complete recovery. So that may affect the aggressiveness with which you operate on patients, anterior, posterior, etc. You should be aware of the three-column spine. The anterior column is made up of the anterior longitudinal ligament and the anterior half of the vertebral body and the disc. The middle column is made up of the posterior longitudinal ligament and the posterior half of the vertebral body and disc. And the posterior column is made up of the posterior elements, including all of the posterior ligaments, which are extremely important, including the interspinous and supraspinous ligament, the ligamentum flavum, the facet capsules, all of which are very important stabilizers of the spine. And according to Francis Denis, who really elaborated the three-column spine, if 2 out of 3 columns are disrupted, then you have an unstable fracture. Now, that does not necessarily mean that you need surgery, but you need aggressive treatment. Typically, what that means is if the middle column is involved, you need aggressive treatment, although there's certainly some fracture patterns where the middle column will be intact. You'll see anterior column injury in compression and posterior column injury in tension. Well, what are some other ways to define whether a fracture pattern is stable or unstable? Well, if you see a translational injury on either the AP or lateral x-ray, that's unstable. And you need to scrutinize, and this doesn't take much scrutiny, but you need to look carefully at both the AP and lateral views. When there is translation, not angulation, but translation, that commonly speaks to a 3-column injury, and that means it's unstable. And if you have an unstable spine like that, you need to stabilize and fuse it. In general, Bradford says that a neurologic injury is the most important clinical indicator of an unstable spine. It has no mechanical significance, but clinically, the presence of a neurologic injury speaks to an unstable spine, and almost any patient with a neurologic injury we're going to wind up operating on, either to try to restore neurologic function, to prevent neurologic worsening in cases where they get better on their own, and many times to stabilize the patient to progress to rehab. When you see incomplete neurologic injuries, those are highly unstable most of the time. We're going to stabilize to protect any recovery they may have made. We're going to decompress if they plateau. And again, just as in the cervical spine, this is increasingly early at many centers. And most of us, if you have an incomplete deficit, if that patient is not neurologically normal within a day or two, we're going to go in and decompress them either anteriorly or posterolaterally, depending on circumstances. And really the controversy is what constitutes an unstable fracture pattern in a neurologically intact patient. In the neurologically normal patient, if they have a translational injury, operate, they're unstable. If they have a posterior ligamentous injury pattern and what looks like a burst fracture anteriorly, that's a patient who really has a highly unstable injury, and you should operate on those patients. Those are the patients with what looks like a relatively mild compression or burst fracture anteriorly. If they've disrupted the posterior ligamentous complex, they are likely to develop progressive kyphosis and come in with increasing pain, increasing kyphosis, and neurologic impairment. The fracture pattern that you see commonly is a burst fracture in a neurologically normal patient. This is a relatively common scenario. Probably if you're going to remember numbers, the standard thing is to operate on patients where the degree of canal compromise is greater than 50%, where the angulation of kyphosis is greater than 20 degrees of what you would see, or when the amount of compression is greater than 50%. And these are the numbers that you see in some of the OKUs. These are the numbers that are talked about. I'm not sure how valid these numbers really are, and I can tell you in my practice, I'm very cautious or very conservative about operating on patients with neurologically normal patients with burst fractures. Wood, in an article in JBJS a couple of years ago, showed that there was no difference between non-operative and operative treatment in the amount of kyphosis at final follow-up, which is the one thing that most people typically say, well, I can make you straight at least, in the degree of stenosis seen at final follow-up, or more importantly, in how much pain or disability the patients had. So really, in practice, I would say if the patient has a true burst fracture, which means they do not have posterior ligamentous disruption, and they are neurologically normal, I would say you should think twice about operating on that patient. And I've rarely regretted non-operatively treating patients with burst fractures. And I can tell you I have certainly regretted operating on several of them. One of the things to be aware of is that when you see more than 20 degrees of kyphosis in a burst fracture, oftentimes you're not dealing with a true burst fracture. You're dealing with a patient who has a vertebral body fracture anteriorly and has disrupted their posterior ligaments posteriorly. How do you pick up that posterior ligamentous injury? Well, one is going back to physical exam, which Nicole described 60 years ago. They're tender posteriorly. They've got ecchymosis posteriorly. You can palpate a gap between the spinous processes posteriorly. Your MRI or your CT scan can be helpful. Your plane films can be helpful. Frequently, the AP view will show widening of the interspinous distance, which you should not see with a true burst fracture. Talked about the surgical indications for burst fracture. Decompression can be done anteriorly, which is the preferred approach for most of us, or can be done through a posterolateral approach. A laminectomy alone does not decompress a burst fracture. You can go posterolaterally down the pedicle and impact the fractured fragment into the defect that's created. Most orthopedic surgeons, and I can tell you most surgeons I've ever worked at, are not that good at doing that. And most of us consider an anterior approach, it's monosegmental disease. Most of us consider an anterior approach, an anterior reconstruction with anterior reconstructive techniques, strut grafting and plating to be the preferred approach nowadays. Certainly if you operate on somebody late where the fracture is healed, an anterior approach is preferred. Another option is the so-called indirect clearance of the spinal canal. So you have 60% retropulsion of bone and you decide I want to operate on that patient. If you realign, distract, and relordose their spine, then you can indirectly clear the spinal canal. You should be aware of the fact that most studies have shown that you only decompress the spinal canal by about 50% in that setting. So in a patient with a significant neurologic deficit, I think most of us prefer a direct decompression to try to restore neurologic function rather than indirect decompression. How do you stabilize a patient with a burst fracture? You can stabilize them anteriorly, and most modern plating techniques are rigid enough that this is considered acceptable stabilization. You can also stabilize them posteriorly if you decide you want to operate posteriorly. Be aware that if you just use a pedicle screw one level above and one level below, single unprotected pedicle screws have a very high risk, 50% risk of breakage and or progressive kyphosis. Now that doesn't always mean, they lose 5 degrees of compression, they go on to heal, they may be fine. But probably a single pedicle screw above and below, or two screws above, a single level above and below, is not considered adequate fixation. And you should either do Roger Jackson's, what he describes as 6 screws, 4 screws above, 2 screws below, with distal hooks under the lamina, or consider anterior strut grafting, some sort of combined approach. Also be aware of the fact, again, that if you distract in the lumbar spine, which is commonly part of the realignment technique, you need to be very careful that you're creating lordosis, you're not losing lordosis. And it's very easy to say, well, I want to distract more, I want to get that fragment out of there. At L3 and below, you have to be very careful that you don't flatten the spine out. Really, you need to be considering the normal sagittal contours at any level. But anywhere, if you're going down to L3 or below, you need to be very careful because loss of lordosis in the mid and lower lumbar spine is a very serious problem. And even in 2005, I see patients who come in after they've had a burst fracture fixed where the fracture looks good, but they now have a flat back syndrome. So you have to be very careful that the patient leave the operating room with restored lordosis in addition to restored height. That's the mark of appropriately done surgery. And also, this is sort of something you could be asked about. If you see a burst fracture and a laminar fracture, there's probably about a 1 in 3 chance that there will be an associated dural tear. And if you see a burst fracture and a laminar fracture and a neurologic injury, there's probably 3 chances in 4 that the patient will have a dural tear. So if you're going to operate posteriorly, you need to be aware of the fact that you're probably going to be dealing with a spinal fluid leak and need to treat that. Some authors suggest that that's an indication not to go anteriorly. I don't think that's true, but you at least need to be aware of the high association between burst fracture, laminar fracture, and the astronomic association between burst fracture, laminar fracture, and neurologic deficit. Chance fracture is also a common, not that common an injury nowadays, but something very easy to write test questions about. And the mechanism is so-called distractive flexion. You're flexing the lumbar spine, but distracting at the same time. Be aware of the associated risk of abdominal visceral injury, which is very high. You can see bony chance injuries, soft tissue chance injuries, and mixed. If they're pure bony injuries, and if you can get it reduced, and if the patient's a reasonable candidate for a cast, or I would rarely use a brace, but for a hyperextension cast, then that's the treatment of choice. If you see a pure soft tissue injury, whether you can get it reduced or not, they're not going to heal. So a soft tissue chance injury is an indication for surgery. And if you see a mixed pattern, which is common, you have to determine, well, is it mostly bony or mostly soft tissue? But unless it's clearly mostly bony and you have anatomic reduction, most of the time I would favor operative treatment. I think that's what you're expected to answer. And then just one last bit about fractures. You will occasionally see fractures in the lower lumbar spine, either at L5 or L4, burst fractures in the lower lumbar spine. This makes up about 4% of all spine fractures, so it's pretty uncommon, but you do see it. The mechanics of healing are different because the lumbar spine is lordotic at that segment, so you've got a fracture that's sitting in a lordotic segment. There's no real flexion moment on it. So we tend to be much more conservative in terms of thinking about surgery. The treatment should usually be non-operative. You should say to yourself, why am I operating on this patient? If you're operating on an L5 or even an L4 burst fracture, the indications for surgery would either be progressive neurologic deficit, always an indication for surgery, progressive deformity in a brace, or sometimes if you see somebody with such a severe neurologic injury with bone across the spinal canal or severe deformity, that would occasionally be an indication to operate. But most of the time, for a low lumbar burst fracture, you should say to yourself, I should be treating this non-operatively. Okay, 59-year-old woman, long history of seropositive rheumatoid arthritis, neck pain, worsening occipital headache, positive Babinski sign bilaterally, so she is a Ranawat 2, right. Radiographs demonstrate 5 millimeters superior migration of the dens, 8 millimeters of C1, C2 motion, and a space available for the cord of 13 millimeters in flexion. Treatment should consist of, B, posterior occipitocervical fusion and halo. She has superior migration of the dens in addition to C1, C2 instability. She's neurologically impaired. She needs surgery. How do you address it? Oh, occipitocervical means down to C2. Yeah. I'm sorry that wasn't more clear. A 19-year-old man sustains a bilateral C5-6 facet dislocation and central cord incomplete injury. Skeletal traction is applied, but closed reduction cannot be achieved. MRI shows an extruded HNP behind the body of C5. Management should now consist of E. anterior C5-6 discectomy, anterior fusion at C5-6, and posterior fusion with wiring, although you could certainly do an anterior C5-6 fusion and anterior plating. You don't want to just come back in 24 hours. The guy's got an incomplete deficit, and the rapidity of reduction is likely to affect his recovery. You don't want to take this guy who you know has a herniated disc down and reduce him asleep because of the risk of making him worse. You don't want to just fuse him posteriorly from the back with a herniated disc and leave the disc in place. And certainly a laminectomy and fusion in situ is a ridiculous answer. A 31-year-old woman injures her neck while skiing. She is neurologically intact. Plain radiographs show a type 2 odontoid fracture with 8 millimeters of posterior displacement. The SAC is 16 millimeters. A red herring. You should recommend right, C, posterior C1, C2 fusion. Now, you could also recommend anterior screw fixation. It's unlikely that they will make you pick between anterior screw fixation and a C1, C2 fusion. You may be expected to know what the relative merits are in words, but it's unlikely that they will give, because either of those is considered an acceptable thing. They may give you a case where you're picking between the two because the person's not a candidate for one or the other. Let's say they have a laminar fracture of C1. That person's not really a good candidate for a C1, C2 fusion, so that raises the benefits of screw fixation anteriorly. Or they show you that oblique fracture line of the dens where you really can't fix that person with screw fixation, which means C1, C2 fixation becomes the right answer. But it's unlikely they give you somebody who's a perfect candidate for either and make you choose, because I don't think there's a consensus nowadays between the two. Okay, a 26-year-old woman is extricated from the back seat of a car in a high-speed wreck. Large transverse abdominal wall abrasion. At laparotomy is discovered to have a sigmoid colon injury. Which associated injury should be suspected? Gaunt-Aquinas syndrome, L5 burst fracture, chance fracture, L3, L4. Right, chance fracture. And the boards are going to be just this easy. Most of these things are going to be relatively common. Don't try to outthink it. If you look back on your OITE experience, and it's a different group that writes the boards, but if you look back, it's the same sort of type of person writing it. They're not trying to trick you. They want you to pass. They're trying to make it relatively straightforward. There are certain principles that they expect you to know. 68-year-old man falls down a flight of stairs, injuring his back. Incomplete neurologic deficit, which resolves after the administration of steroids. AP and lateral radiographs demonstrate a severe compression fracture. 4 millimeters of anterior and 3 millimeters of lateral subluxation of T12 on L1. Appropriate treatment would consist of observation for 48 hours, then plaster body cast, mobilization, L1 corpectomy. Well, you could do an L1 corpectomy, I guess, an anterior fusion, although why you would do that I'm not really sure. He doesn't need a corpectomy. The treatment of choice would be posterior stabilization. In general, you can stabilize somebody much more effectively from the back. You can realign a subtle subluxation more effectively from the back. This would really be less than ideal, although this is probably not so completely wrong as to be obvious. Okay, let's talk for a few minutes about lumbar disc disease, then I'm going to stop. Low back pain is almost ubiquitous in the adult population. It's been estimated that 50% to 80% of the adult population in the United States is going to have an episode of low back pain at some time in their life, and the combined direct and indirect costs of low back pain in this country alone are as high as $100 billion. And you can run a nice little war in a Middle Eastern country for that kind of money. So we're talking about some significant money. The direct costs alone are somewhere between $25 and $50 billion in low back pain. And we know the natural history in that at least 90% of patients with an acute episode of low back pain are going to resolve in the first month. The risk factors for low back pain and lumbar disc disease include obesity, smoking. It's probably more common in men than in women. Other studies have shown that a history of lifting on the job, driving certain motorized vehicles, the vibration causes trouble with your back. Prolonged sitting on the job is associated with back pain. And interestingly, some of the work studies show that the number one risk to have a work injury in the next month is either that you're unhappy with your job, or other studies have shown that if you have a bad job evaluation for your employer, you're at significant risk for, lo and behold, injuring your back on the job. And there's a lot of basic science that goes into it. There are diminished cellular responses as the disc degenerates. There's a number of biochemical processes that are seen. If there's one buzzword to try to remember, it's the presence of cytokines in the disc that, as in a number of other of our body's tissues, sort of just lead to this negative cascade, if you will, of degeneration. There are changes in the end plate with lumbar disc disease. There are changes seen in the dorsal root ganglia, particularly in patients with chronic pain. And there are changes in the sinovertebral nerve and the nociceptors that are also seen when you do basic science analysis of the motion segment. Basically, what you want to do when you evaluate a patient with low back pain is you want to look for red flags first and foremost, and then you want to leave the patient alone. So red flags are indicators of either tumor, infection, or trauma that suggest that there's something other than just your garden variety backache. In the absence of red flags suggesting tumor, infection, or significant trauma, and in the absence of a Cauda-Equina syndrome, the overwhelming majority of the patients should be basically treated with benign neglect. They don't need imaging studies. They don't need physical therapy. They don't need anything other than moist heat, non-steroidal anti-inflammatories, a little bit of rest, not bed rest, and then progress their activity as tolerated. The only role for imaging would be if you have a red flag and you say, gee, I know this patient has a history of cancer, she's lost 15 pounds in the last 6 months, she can't sleep at night, then that would be somebody to pursue an MRI for, or somebody with significant risk factors, an IV drug abuser, history of fevers and chills, relentless back pain, or if they fail non-operative treatment for at least the first month. But in general, and this is the kind of question you may be asked, you do not get x-rays, MRI, or anything else in the first month for an acute episode of back pain, and I would include radiculopathy in that, in the absence of some good reason to get them. Now, talking about lumbar disc disease, L4, L5 is the most common level seen in lumbar disc disease. Lumbar disc disease is believed to begin because of recurrent torsional strain causing tears of the outer fibers of the annulus. Those tears coalesce into larger tears through which can occur herniation of the nucleus pulposus. Lumbar spondylosis, which is this disc degeneration, involves disc desiccation and collapse, progressive facet arthrosis, disc bulging and osteophytosis, and what this leads to is abnormal kinematics of the motion segment, which then leads to further degeneration, just like it does for a lot of joints. The question is, what is really the significance of lumbar spondylosis, which is, in many people's estimation, really a normal part of the aging process. Again, be aware of the high rate of abnormal MRI scan. And I realize this is a number-heavy slide, but in general, between the ages of 20 and 40, remember that there's a 20% risk of seeing a disc herniation on an MRI scan. Between the ages of 40 and 60, still only about 20% disc herniation and about 50% disc bulging or degeneration. And when you go between the ages of 60 and 80, you get up to about a third of patients have a disc herniation, 20% have stenosis, and about 80 to 90% have bulging or degeneration. So again, that's a lot of numbers to remember, but you may be asked some of these numbers. They do like to ask this kind of thing. When you have, sure sign of somebody falling asleep. When you have a disc herniation, far and away the most common type of disc herniation is a posterolateral disc herniation. Probably 90 to 95% of disc herniations are posterolateral, meaning that they occur at the lateral margin of the posterior longitudinal ligament under the traversing or lower numbered nerve root. So at L4, L5, the majority of the time you're going to get the L5 nerve root. Remember, at C4, C5, you always get the C5 nerve root. At L4, L5, you almost always get the L5 root, but occasionally you'll see a foraminal or far lateral disc herniation, 5 or maybe 10% of cases, and in that case, you can get the exiting or upper numbered nerve root. So for the L4 or 5, that would be the L4 nerve root. But when in doubt, guess L5 or C5, because most of the time that's going to be right. But certainly, you know, as a board-certified orthopedic surgeon, if they show you a classic foraminal disc herniation out lateral, they expect you to realize that that's the L4 root and know the associated neurologic findings at the L4 or L5 level. The diagnosis is made by history and physical examination. X-rays are of very limited utility. You should wait at least 4 weeks before getting X-rays, and plain films really have very little use, with rare exception, even leading up to surgery. I would almost always get them because they're part of surgical planning in somebody I've identified as a surgical patient, but just getting plain films for the sake of getting plain films rarely tells you anything of any importance in terms of therapeutic decision making. And certainly you should wait at least 4 weeks, and they're completely nonspecific. EMG testing has very little role in the routine evaluation of patients with back pain and or lumbar radiculopathy, and it tells you almost nothing that a good history and physical exam doesn't. Neuroradiography is most of the time an MRI scan nowadays. The MRI scan is highly sensitive, highly specific, but clinical correlation is essential primarily because we know that no matter what else the patient may have done yesterday when he got hurt on the job, he's got those significant numbers or significant chances of having abnormal findings before he ever hurt himself. So you have to be very careful about interpreting your MRI scan, and therefore you should be very careful about ordering the MRI scan. It really should be considered a preoperative test, not just, you know, I want my patient to realize I care. Gee, this is the juiciest disc I think I've seen in 9 months, and I want to get an MRI scan to confirm my suspicion. But it should be considered a preoperative test. Be aware of the significance of the tension sign, i.e. the straight leg raising sign, or in some cases the femoral nerve stretch test. It is the most important and most predictive physical finding for identifying who is a good candidate for surgery. The straight leg raising sign can be done sitting or supine, and in the supine position, it reproduces the patient's pain and or paresthesias between about 30 to 70 degrees of hip flexion with the knee straight. It should reproduce the patient's leg pain, not their back pain, to be considered positive. The straight leg raising sign is helpful for L5 or S1 radiculopathies. For L4, it's really not that helpful. And certainly by L3, you need to do a femoral nerve stretch test, which is the equivalent tension sign. In general, as we'll see in a minute, you really should think to yourself, am I doing the right thing operating on somebody for a disc herniation if they don't have a straight leg raising sign? Because there's good evidence that you get good results when they have a straight leg raising sign and all the other indicators, and you don't get very good results if they don't have a straight leg raising sign because they don't have radiculitis in that setting. The natural history of disc herniations, not just disc disease, but disc herniations, is that most patients, 90% or more, improve without surgery. Most patients with disc herniation are better in at least if you wait 4 to 6 weeks, and a number of them will get better if you wait another 6 weeks. In general, the operative and the non-operative results are equal if you wait 4 years, and many times they're better if you wait a year. What does that mean? That means the good candidate for surgery is somebody who either laughs in your face, spits at you, or is walking out the door when you start to tell them, well, you know, if we wait a year, your pain will get better. The good candidates for surgery are patients who are so miserable after 4 to 6 or 8 weeks that they don't want to think about waiting another day, let alone a few more months. In general, though, for disc herniations, non-operative treatment is best. Non-operative treatment should be pursued for at least 4 to 6 weeks, and certainly that's the right answer on the boards. And that's the right answer in practice, don't get me wrong. Non-operative treatment includes rest, not bed rest, but activity restriction, a few days off from work, moist heat, non-steroidals. If the patient's not getting better after a couple of weeks, maybe send them to physical therapy for some modalities, but in general, they don't usually need that. When they get better, you send them to physical therapy, typically for extension exercises in lumbar disc herniations. Injections are about 50% effective. In an article in JBJS last year by Butterman et al., they showed that surgical candidates 50% of the time will get better with an injection, and when they get better, they tend to stay better. Dan Rue from WashU several years ago showed that in discs and in stenosis that his results may even have been higher. Patients on the surgical schedule, about 50% of the time, come off the surgical schedule if you send them for either epidural steroids or selective nerve blocks. And when they get better, they tend to stay better. So you really should say to yourself when you're operating for discs or stenosis, which we'll see in a minute, why have I not sent this patient for injections? And sad to say, in the surgical community, although I think much so among some of our surgical brothers and sisters in the neurosurgical community, I think it's because they will get better if I send them for injections. So when is surgery indicated? Well, surgery is certainly indicated if they have a cauda equina syndrome and a herniated disc. Surgery is indicated if the patient has progressive, significant weakness, not just a little EHL weakness, not just an ankle jerk that's asymmetric compared to the other side, but if they come in with significant weakness of ankle dorsiflexion or their quads are buckling, and certainly if it's getting worse, then that's a patient that most of us would operate on. Far and away and that's rare in disc herniations, by the way. Far and away the most clear-cut indication for surgery is persistent, disabling pain that's lasted for more than 4 to 6 weeks. And I would really say 6 weeks. I think you should wait 6 weeks. You should try epidural steroids. And most patients will get better. And you do get a lot of patients in that gray zone. They go from 10 out of 10 to 4 out of 10. They ain't happy at 4 out of 10, but they're not sure it's really worth an operation. And that's really the problem. But be that as it may, you really should operate. You really should treat patients non-operatively, aggressively, and take pride when you get patients with disc herniations better non-operatively, not just that you've lost a surgical case. Who is a candidate for surgery? Well, there are 4 things that go into being a good candidate for surgery. One is sciatica should be your chief complaint. Pain and or paresthesias down one leg in a clear-cut dermatomal distribution. That they may complain chiefly of pain in the buttocks, but they should have symptoms distal to the knee for lower lumbar disc herniations, which is what the majority of disc herniations are. It's nice, although not essential, to see an abnormal neurologic finding. You should see a tension sign, and if you don't, you should ask yourself, is surgery the right thing? And then and only then you get a confirmatory MRI scan. Is it the right side as the patient's complaints of pain? There are no contractile lesions in the lumbar spine. Is it the level that I think it should be? And sometimes you're off by a level, maybe. But if you think somebody has an L5, S1 disc and an S1 radiculopathy, and they've got a big bulging disc at L2, L3, that is not what's causing this patient's pain, and you're not going to get them better. Surgery is an excellent operation in the right patient. 90% plus of patients get 90% plus relief of their leg pain. Unfortunately, 15 to 30% have persistent back pain. It is not really a good operation for back pain. And in fact, when you operate on patients who tell you, my main problem is my back pain, that's what gives back surgery a bad name. Neurologic recovery is much less predictable. Only 50% of patients will make complete recovery of motor or sensory loss. And only 25% of patients will get their reflexes back, which has no significance whatsoever, except the yuppies in Washington, at least, who perseverate on that. Complications of disc surgery are not uncommon. They include dural tear, probably in 1% of normal, of first-time disc herniations. This is a common test question. If you have a dural tear, you want to repair the tear, a watertight repair at the time of surgery, and essentially do whatever it takes to get a watertight repair. If you have a CSF leak in the postoperative period, then a very acceptable alternative is to put a subarachnoid drain in. If you have someone who has a dural tear and undergoes an uncomplicated repair, their prognosis is as good as patients who don't have a dural tear. And those are the kinds of results that were published in JBJS in the last decade that you might be asked again, about. Recurrent disc herniation occurs in anywhere from about 3 to 13% of patients, should be treated non-operatively. If they fail non-operative treatment, patients should have surgery. Discitis is seen in about 1% of uncomplicated disc herniations. We'll talk about that in spine infections. And vascular catastrophe is exceedingly rare, but if you see blood coming through the disc space when you're working away in the rongeur, and it's when you're using the rongeur that it's most likely to occur, you need to turn the patient over, get a vascular surgery consult as soon as possible, and do a laparotomy.